Insert the canisters into the canister holders or canister rings if applicable. Connect the color-coded reusable vacuum tubing from both high and low vacuum ports to the vacuum ports of back canisters. Close all unused vacuum ports on the canister lids. Tandem connect the front canisters to the back canisters using tandem tubing. Tandem tubing connects to the ports labeled tandem. Place the tissue trap into the front high vacuum canister. Connect the blue connector to the patient under buttock drape. Connect Y tubing to the patient port of the front low vacuum canister. Connect the yellow Luer lock to the hysteroscope outflow channel marked by the yellow arrow. Insert seals into both the hysteroscope and the back of the outflow channel to prevent splashback. Insert the outflow channel into the hysteroscope. Turn on the Aqualex fluid control system. The system will perform an automatic self-diagnostic test. Insert the inflow tubing into the pump head. Connect the blue Luer lock to the hysteroscope inflow channel marked by a blue arrow. Hang the fluid bags. Spike the bags. Open the inflow stopcock. Press the prime button. The prime mode will purge air from the tubing and complete the automatic lumen calibration, ensuring optimal inflow at all times during the procedure. Once prime is completed, you will hear a beep. Close the hysteroscope inflow stopcock. Test the vacuum level by placing a finger over the tissue trap opening and the patient port to ensure that the canisters are sealed. Set the intrauterine pressure using the up and down arrows to adjust. Set the appropriate deficit limit using the up and down arrows to adjust. Press the 0 button to reset the deficit to 0 once the priming has completed.
The Myosure system enables simple and efficient hysteroscopic removal of tissue. To achieve and maintain uterine distension and optimal visualization while rapidly cutting and removing tissue, it is important to understand the unique fluid characteristics of the Myosure procedure. Inflow of normal saline is achieved by a fluid pump that provides adjustable fluid pressure. It is important to properly set the fluid pump pressure and inflow rates based on the recommendations in the Myosure Setup Guide. The Myosure outflow channel provides continuous flow during the diagnostic procedure and is removed once pathology is confirmed. The Myosure device now becomes the outflow channel. Active suction is required to remove tissue through the Myosure device. When the Myosure foot pedal is activated, the cutting window is opened and suction pulls fluid and tissue from the uterine cavity through the Myosure device and into the tissue trap. To maintain distension while suction is activated, infusion of fluid into the uterus must be at a fluid flow rate and pressure to establish a balance between the two. This may necessitate periodic adjustments of increased pump pressure to maintain the desired uterine distension. Each fluid pump performs differently, and therefore an adjustable suction source should be used during the Myosure procedure to provide vacuum pressure adjustments based on the inflow performance of the fluid pump used. It is important to set the vacuum pressure based on the recommendations in the Myosure setup guide. The vacuum pressure significantly affects uterine distension and cutting efficiency. If the vacuum is set too high, distension will deteriorate quickly when Myosure is activated. If set too low, obscuring tissue may not be evacuated at the desired rate, and venous absorption of fluid may become an issue. It is important that the physician and staff monitor fluid deficit volume throughout the procedure. In accordance with the ACOG guidelines, the procedure must be stopped if this value exceeds 2,500 cc's. Creating a balance of fluid inflow and suction is the most important concept to understand for the Myosure procedure. If visualization and cutting performance is compromised, periodic adjustment of fluid pressure and suction should be performed. Always orient the Myosure cutting window against tissue before the foot pedal is activated. This will minimize the evacuation of fluid during cutting activation. If bleeding occurs, extend the Myosure device past the scope and wait a few seconds for the fluid to circulate through the closed Myosure window. The closed window still has a small area around the blade for outflow. At this point, you may want to consider making one of the following adjustments. 1. A tapenade effect may be achieved by increasing the fluid pressure. 2. Reducing suction will lower the rate at which fluid is evacuated and intrauterine pressure decreases. Always monitor fluid deficit throughout the procedure in accordance to the ACOG guidelines. Thank you for your attention.
Before utilizing the NovaSure RF controller, ensure that proper facility protocols regarding the use of RF generators have been met. Place the NovaSure RF controller on a small table to one side of the patient within the visual field of the physician. Attach an AC power cord to the NovaSure RF controller and plug into an AC outlet. Screw the CO2 canister into the regulator on the back panel of the controller until tight. If your controller is equipped with a CO2 regulator knob, turn the knob clockwise until the word high is in line with the silver arrow on the regulator. Press the toggle switch on the back panel of the controller to the on position. Connect the foot switch to the appropriate port on the front panel of the NovaSure RF controller. Open the sterile NovaSure device package. Place the disposable device with the connecting cord into the sterile field while being careful to keep the non-sterile suction line desiccant pouch out of the sterile field. Open the non-sterile suction line desiccant pouch. If the suction line desiccant is pink, replace the desiccant prior to initiating the ablation procedure. Remove the red caps and connect the desiccant filter barbs into the suction tubing of the disposable device. Ensure both ends of the desiccant filter are fully inserted. Before the physician inserts the device into the patient, connect the disposable device cord to the appropriate port on the front panel of the controller. Once connected, you should hear an audible beep in conjunction with a flashing red cavity assessment LED on the front of the NovaSure RF controller. This indicates that the air is being purged from the vacuum suction lines. Once this process is complete, it is safe for the physician to insert the disposable device into the patient. When plugging the disposable device in, you should also notice a red LED appear next to array position on the front of the NovaSure RF controller. This LED should extinguish once the NovaSure disposable device is deployed by the physician. Adjust the cavity length on the length setting feature of the device to the value of the uterine cavity sounding length. Key this cavity length into the NovaSure RF controller length LED by depressing the up and down arrows. For the purposes of this demonstration, a cavity length of 5.5 centimeters will be used. The physician will now insert and seat the disposable device in the uterine cavity. When proper placement has been achieved, a cornu-to-cornu width measurement will be obtained from the width dial. Key the value indicated on the width dial of the NovaSure disposable device into the NovaSure RF controller width setting by depressing the up and down arrows. The width of the cavity should be at least 2.5 centimeters before proceeding. The NovaSure RF controller can be operated in two different modes, automatic mode and semi-automatic mode. Please note, in some Model 9 RF controllers, a vacuum pre-check occurs automatically prior to the initiation of the ablation cycle. The vacuum LED will flash and an audible tone will be heard for up to 10 seconds during the vacuum pre-check. To operate the system in the automatic mode, press the Enable button prior to beginning the cavity integrity assessment. Begin the cavity integrity assessment procedure by stepping on the foot pedal once. Upon successful completion of the cavity integrity assessment, the ablation cycle will start automatically. To operate the system in the semi-automatic mode, do not press the Enable button prior to beginning the cavity integrity test. Begin the cavity integrity assessment procedure by stepping on the foot pedal once. Upon successful completion of the cavity integrity assessment, indicated by a steady green light, press the Enable button. The ablation will not start until the physician depresses the foot pedal again. During the ablation cycle, a blue RF on LED will illuminate on the front of the controller. Completion of the procedure is indicated by a green Procedure Complete LED on the front of the NovaSure RF controller. Once the procedure is complete, turn off the NovaSure RF controller. If equipped, close the CO2 regulator. Unplug the NovaSure disposable device. Perform post-operative patient care according to standard procedures. The used disposable device must be treated as biohazardous waste and disposed of according to standard practices of the hospital, office, or clinic where the treatment is performed. An important tip regarding the audible CO2 alarm. If at any point in time when the NovaSure RF controller is on and the CO2 regulator is not on, or the CO2 canister is empty, the NovaSure RF controller will generate an audible alarm at a rate of 4 times per second. Depressing the foot switch will not turn off the audible alarm. To silence the alarm, if your machine is equipped with a regulator, ensure that the regulator is turned to high. If this does not correct the issue, replace the CO2 canister to stop the audible alarm. It is not necessary to remove the device from the patient in order to replace the CO2 canister. CO2 alarms that occur during the energy delivery portion of the procedure will not affect the patient or the ablation.
To begin, plug in the console and turn it on. A system startup screen appears while the console runs a self-diagnostic test. The screen will now prompt you through all steps of setup. The Genesis HTA Pro Server procedure set comes in 2 trays. The first holds the cassette and drainage bag. The second holds the sterile procedure sheath. Slide the cassette down until it is fully seated. 2 blue lights behind the cassette will illuminate. Hang the drain bag on the console and connect the drain line lure fitting from the cassette to the drain bag. Press the right-hand console button to engage the cassette. Once the system checks the cassette, the remaining setup steps will be displayed on the screen. Hang a 3-liter bag of saline on the IV pole. Then spike the saline bag. Now check to confirm that the tubing clamps are open. Next, while observing sterile technique, open the procedure sheath tray. Be sure to remove the 2 dust caps from the sheath and the 2 dust caps from the cassette. Connect the sheath's inflow and outflow tubing to match the color-coded connections on the cassette. Next, attach the scope adapter to the proximal end of the procedure sheath by pushing the adapter over the O-ring and screwing into place. Carefully guide the hysteroscope through the procedure sheath until it stops in the scope adapter. Then connect the hysteroscope to the adapter. Now attach the sheath cap to the tip of the procedure sheath and press the right console button. The system will now initialize and fill. Set the console height by aligning the console's handle or the laser aiming beam with the height of the patient's uterus. To adjust the height, simply loosen the adjustment knob and gently raise or lower the console to the proper height, and then retighten the knob. Setup is now complete. To prepare the patient, begin by exposing the cervix with a vaginal speculum. Ensure that the vaginal speculum has adequate length and width to provide a 360-degree view of the cervix. Attach the tenaculum to the cervix. Dilate the cervix to approximately 8 millimeters, or 24 French, being careful not to over-dilate. It is recommended to use Hagar dilators. Please be mindful when advancing the dilators to avoid uterine perforation. Next, remove the sheath cap and press the right console button to initiate diagnostic hysteroscopy, and carefully insert the sheath into the cervix. The sheath should always be advanced under direct visualization. During hysteroscopy, the patient's uterus is flushed with room temperature saline to allow for diagnostic examination. Please note that pressing pause at any time will suspend the procedure and stop flow to the patient. To resume the procedure, press the right console button. During hysteroscopy, observe the uterine cavity to identify anatomic landmarks, in particular the tubal ostia. When hysteroscopy is complete, press the right console button to continue to ablation preparation. The system will begin ablation preparation by prompting you to position the procedure sheath within the uterine cavity. Once in position, place the tenaculum onto the sheath's tenaculum stabilizer, then slide the upright white tab backward until it touches the tenaculum's T or ratchet. Push the right console button to continue with ablation preparation. Before ablation is initiated, the system performs a seal integrity check. During this phase, room temperature saline is circulated in the uterus. Throughout this closed-loop phase, fluid level and temperature are monitored and displayed on the screen. Once you observe a stable fluid level and are confident that you have a good cervical seal, initiate ablation by pressing the right console button. The Genesis console will now begin heat-up of the saline. Once heating has begun, it is important to maintain a stable sheath position. Throughout the heat-up and ablation phases, fluid level and fluid temperature are updated on the screen. When the fluid reaches 80 degrees centigrade, a chime will sound and the 10-minute ablation timer will be displayed. During ablation, the fluid temperature continues to rise to 90 degrees centigrade. The heated, free-flowing saline will conform to the uterine cavity, enabling the treatment of a variety of patients. The Genesis HTA system allows for viewing of the entire ablation from start to finish. As shown in this time-lapse sequence, the pink cavity blanches white as the procedure advances. When ablation is complete, the system automatically begins flushing the uterus with room temperature saline for 90 seconds. Do not remove the sheath until the cool-down process is complete. A chime will indicate that cooling and flushing is complete and that the fluid temperature is less than 45 degrees centigrade. Release the tenaculum stabilizer by pressing the upright tab down and sliding it forward. You are now presented with the option to continue to system shutdown or perform additional diagnostic hysteroscopy. You have the opportunity for up to 10 minutes of post-ablation hysteroscopy. During this phase, room temperature saline is cycled through the sheath, into the uterus, and then into the drainage bag. To end diagnostic hysteroscopy at any time, press the right console button to complete the procedure. You will be prompted to remove the procedure sheath from the cervical canal and reattach the sheath cap. Press the right console button to continue with system shutdown. Next, the system will instruct you to clamp the saline bag. Then clamp, disconnect, and cap the drainage bag. To release the cassette, press the right console button. System shutdown is now complete. If the hysteroscope and scope adapter have not been removed, you may do so now. Then dispose of the saline bag, procedure set, and drainage bag.
The setup and use of the GYNE ThermaChoice system is straightforward. To begin, plug the power cord into the back of the controller and into the wall outlet. Open a sterile package containing the GYNE ThermaChoice balloon catheter and syringe and gently set them on a medical tray. The GYNE ThermaChoice balloon catheter should only be handled by a person who has been properly scrubbed and gowned. When removing from packaging, smooth over the tubing to remove any kinks or package memory. The filter, which is on the end of the catheter's pressure line, is attached to the controller, ensuring that the connection is snug. Do not over-tighten. Firmly insert the catheter circulation plug into the circulation port. You will hear a slight click as it is secured into place. Ensure that the connection is locked by slightly pulling back on the plug. Once this is done, the umbilical cable, which is not sterile and needs to be either draped or disinfected by wiping it with a 70% isopropyl alcohol dampened cloth, is connected to the controller. The red dot on the umbilical cable should point up as it is connected. Once again, you will hear a click as it is secured into place. The other end of the umbilical cable is then connected with the catheter's extended cable receptacle. The arrows of the cable should line up with the white notch on the catheter's cable receptacle. As they are secured together, you will hear and feel a click. You are now ready to turn the controller power switch on. With the power on and the catheter fully connected, the message display will read Prime Catheter. The catheter is then primed. Priming evacuates the air and creates a low-profile balloon for insertion into the uterus. To prime the catheter, first fill the syringe slowly with up to 20 cc's of D5W. Use only sterile injectable D5W solution. Use of other fluids may compromise the catheter. Then firmly attach the syringe to the catheter. Hold the catheter, pointing it down to the floor, and depress the trumpet valve, filling the balloon with up to 20 cc's of fluid. When adding fluid during priming, ensure that the balloon fully opens so that none of its sides are touching. Once again, depress the trumpet valve, but this time slowly aspirate both fluid and air from the balloon until a negative pressure of -150 to -200 millimeters of mercury is reached, as indicated on the controller's pressure display. You may need to purge air from the syringe several times to attain the desired negative pressure. Note, never exceed -200 millimeters of mercury pressure. Now, release the trumpet valve to maintain a stable negative pressure for at least 10 seconds, after which you are ready to proceed with the next steps of the procedure. Before beginning a procedure, you should become familiar with the controller's error messages and prompt codes. The message prompts guide you through the procedure. Successful completion of one step will trigger the next one. The error codes alert you when a problem occurs. Please consult the user manual for a complete listing of these codes. Additionally, for quick reference, a user card which pulls out from underneath the controller allows you to review the key steps necessary to perform the procedure. Next, a syringe is prepared with 30 cc's of D5W. Once this is done, the syringe is reattached to the catheter. The balloon is then moistened with D5W. This will provide added lubrication prior to its insertion. It is recommended that a non-steroidal anti-inflammatory drug NSAID be given at least 1 hour prior to treatment and continued postoperatively as necessary to reduce intraoperative and postoperative uterine cramping. At this point, the patient should already be prepared for the procedure, with anesthesia administered. It is also important to measure the depth of the uterus with a uterine sound and ensure that the cervix is dilated to 5 millimeters as necessary. The GYNE ThermaChoice balloon catheter is now gently inserted transcervically into the uterus until the catheter tip touches the fundus. Do not use excessive force during insertion. Ensure that the depth marking on the catheter is consistent with the sound measurement that was previously taken. It is often helpful to use a tenaculum to hold the cervix and realign the uterus during catheter insertion. Since it is important to keep the heating coil centered in the uterus during therapy, use of a tenaculum can also help maintain proper alignment of the uterus during the therapy cycle. The balloon is slowly filled to approximately 160 to 180 millimeters mercury using between 2 and 30 cc's of fluid. At this point, up to 5 cc's additional fluid may be added if needed. Draw up to 5 cc's of D5W from the bowl into the syringe. Attach the syringe to the catheter and release the trumpet valve to inject the fluid slowly into the catheter. At these pressures, the extremely elastic balloon conforms well to the shape of the uterine cavity. To ensure maximum balloon coverage of the endometrium, proper and careful pressure titration is required. During a typical titration process, small volumes of fluid are incrementally added, followed by decreases in pressure due to natural uterine relaxation. It is important to titrate slowly and carefully for optimal results. The goal of pressure titration is to reach and maintain a stable pressure between 160 and 180 millimeters mercury of pressure for a minimum of 30 seconds. Note: never titrate the pressure to more than 200 millimeters of mercury, as this can later lead to overpressure warnings and even procedure termination. Also, remember to release the trumpet valve after each addition of fluid in order to stabilize the pressure. During pressure titration, the message display prompts you to fill the balloon and stabilize the start pressure above 150 millimeters mercury at a minimum. Important: if pressure cannot be stabilized at 160 to 180 millimeters of mercury for 30 to 45 seconds with up to 35 milliliters of fluid, this may indicate uterine perforation. Should this happen, remove the balloon catheter. If a balloon leak is present, replace the catheter and continue with the procedure. If no balloon leak is found, perform appropriate diagnostic measure to evaluate for perforation before proceeding. If perforation cannot be ruled out, abandon the procedure. Note: once the heater is activated, the pressure may initially rise 10 to 20 millimeters mercury. The pressure may then drop slowly for the remainder of the procedure. Once a pressure of 160 to 180 millimeters of mercury has been stabilized for at least 30 seconds, therapy can now be initiated. It is no longer necessary to maintain contact with the fundus. Note: proper and careful pressure titration is extremely important to ensure maximum balloon coverage of the endometrium. Once a steady pressure of 160 to 180 millimeters mercury is maintained, the message display panel will read, "Ready, press start." Press the start button on the controller. Once started, the controller activates the heater to achieve a treatment temperature of 87 degrees centigrade or approximately 188 degrees Fahrenheit. This normally takes between 15 to 45 seconds, but can take up to 4 minutes. The impeller at the tip of the catheter begins to circulate the heated fluid inside the balloon and continues throughout the therapy cycle. Once 87 degrees is reached, an audible tone indicates the automatic activation of the 8-minute therapy cycle. Therapy time elapsed is shown on the controller's time display. After the preheat cycle is complete, the time resets to 0 minutes and seconds. The displayed time is the exact therapy time. Throughout the procedure, the controller will continuously monitor pressure, regulate temperature, and track therapy time. Note, it is important that no fluid be added after the treatment process has been started, as this could create, or exacerbate if already present, a uterine defect, such as a perforation. You will notice that the pressure may rise slightly with initial heating. It is quite common to then see the pressure gradually drop during the procedure. This pressure decline will not adversely affect the treatment, but can be minimized with careful titration of balloon pressure prior to treatment. When the treatment is complete, the controller automatically terminates the procedure. The therapy time elapsed, which is 8 minutes, is shown on the time display. Upon completion of the therapy cycle, the heater is automatically deactivated and the fluid is allowed to cool for 30 seconds. You'll notice that the time display now indicates the total therapy time of 8 minutes, plus the original preheat time. Once the fluid is cooled, the message display will read "Therapy and cool down completed," and then "Remove fluid, remove catheter." Deflate the balloon by depressing the trumpet valve and removing all the fluid. Then withdraw the catheter from the uterus. Ablation occurs via thermal necrosis or destruction of the endometrium into the superficial myometrium. This necrotic tissue is sloughed off, much like the uterine lining is sloughed off during menses, usually causing a significant reduction or complete elimination of menstruation. After the catheter has been removed, the pressure line and circulation plug are disconnected from the controller. The umbilical cable and catheter are disconnected from each other, and the cable is disconnected from the unit and disinfected for the next case. Once this is done, the catheter is discarded. This concludes the in-service demonstration for the GYNE ThermaChoice 3 Uterine Balloon Therapy System.